The earliest priorities in managing the injured patient are to ensure an intact airway and recognize a compromised airway. Trauma team priorities are to ensure an adequate airway, ensure adequate oxygen delivery, and ensure adequate ventilation. Remember that supplemental oxygen must be administered to all trauma patients. Note these causes of early preventable death and disability from airway compromise associated with trauma. This module will explain how to avoid these pitfalls. Toward identifying and managing potentially life-threatening airway compromise are to recognize objective signs of airway obstruction and any trauma or burns involving the face, neck, and larynx. A talking patient suggests that, at the moment, the patient has an open airway, brain perfusion, and is ventilating. Failure to respond or an inappropriate response suggests an altered level of consciousness that may be a result of airway or ventilatory compromise, or both. Patients with an altered level of consciousness are at particular risk for airway compromise and often require a definitive airway to ensure a secure, functional airway. Maintaining oxygenation and preventing hypercarbia are critical in managing trauma patients, especially those who have sustained head injuries. In these patients at risk for compromised ventilation, the purpose of endotracheal intubation is to provide an airway, deliver supplementary oxygen, support ventilation, and prevent aspiration. Patients with maxillofacial trauma who refuse to lie down may be experiencing difficulty maintaining their airway or handling secretions. Also, providing general anesthesia, sedation, or muscle relaxation to these patients can lead to total airway loss due to diminished or absent muscle tone. Understanding the type of injury is mandatory to provide adequate airway management while anticipating the risks. Initially, patients with serious neck injuries may be able to maintain airway patency and ventilation. However, if airway compromise is suspected, a definitive airway is warranted. In patients with laryngeal fracture, complete airway obstruction or severe respiratory distress warrants attempted intubation. If intubation is unsuccessful, an emergency tracheostomy is indicated, followed by operative repair. Surgical cricothyroidotomy, although not preferred, can be a life-saving option. Require quick and accurate assessment of airway patency and adequacy of ventilation. Pulse oximetry and end-tidal carbon dioxide measurements are important. If problems are identified or suspected, take immediate measures to improve oxygenation and reduce the risk of further ventilatory compromise. These measures include airway maintenance techniques, definitive airway measures, and methods of providing supplemental ventilation. This lesson addresses the topics of predicting difficult airways and performing airway maintenance techniques, from the chin lift maneuver to definitive airways to surgical airways. Because all of these actions potentially require neck motion, maintain C-spine protection in all trauma patients at risk for spinal injury until it has been excluded by appropriate radiographic adjuncts and clinical evaluation. Even in patients with patent airways, you may need to intervene to secure the airway and facilitate breathing. Patients who are wearing a helmet and require airway management need their head and neck held in a neutral position while the helmet is removed by two people. Assess the patient prior to attempting intubation in order to predict the likely difficulty of the maneuver. The Lemon mnemonic guides this assessment. When you predict a difficult airway, seek the assistance of skilled team members when possible. Drug-assisted intubation may be necessary. The Airway Decision Scheme is an algorithm for deciding the appropriate route of airway management for these types of patients. This is a general approach to airway management in trauma, but many centers have developed their own detailed airway management algorithms, so it's important to review and learn the standard used in your trauma system. Oxygenation levels greater than 90% and ventilation must be maintained before, during, and after insertion of a definitive airway. Avoid prolonged periods of inadequate or absent ventilation and oxygenation at any time. In patients with decreased level of consciousness, the tongue can fall backward and obstruct the hypopharynx. You can readily correct this form of obstruction using the chin lift or jaw thrust maneuvers. The airway can then be maintained with an oropharyngeal or nasopharyngeal airway. Remember, airway management maneuvers can produce or aggravate C-spine injury, so inline immobilization is essential. Before insertion, the size of oropharyngeal airway and nasopharyngeal airway needs to be determined based upon patient size. Both airways are more easily inserted if lightly wet or lubricated. Avoid these basic adjuncts in patients with mid-face fractures.
Take the collar off and go ahead and come in and support the neck. All right, good. I'm going to do a jaw thrust here. Fingers behind the mandibles. Pull up. Once we get that up, we can transition to the bag and bag. All right, come in and get the jaw thrust up. Okay, I got it. All right.
Select the proper size airway. A correct sized airway extends from the corner of the patient's mouth to the external auditory canal. Insert a tongue blade on top of the patient's tongue far enough back to depress the tongue adequately. Be careful not to cause the patient to gag. Insert the airway posteriorly, gently sliding the airway over the curvature of the tongue until the device's flange rests on top of the patient's lips. The airway must not push the tongue backward and block the airway. Remove the tongue blade and ventilate the patient with a bag mask device.
Laryngeal mask airways and intubating LMAs play a role in managing patients who require an advanced airway adjunct, but in whom intubation has failed or is unlikely to succeed. The laryngeal tube airway is an extraglottic airway device with capabilities similar to those of the LMA in providing successful patient ventilation. The intubating laryngeal tube airway is an evolution of the device that allows intubation through the LTA. There are three types of definitive airways: orotracheal tubes, nasotracheal tubes, and surgical airways. The urgency of the situation and the severity of circumstances dictate the need for airway intervention and the specific route and method to be used. The criteria for establishing a definitive airway is based on the clinical findings outlined here. Remember, the potential for concomitant C-spine injury is a major concern in patients requiring a definitive airway. Also, radiological studies should not impede or delay placement of a definitive airway when one is clearly indicated. The most important determinants of whether to use the orotracheal or nasotracheal intubation technique are the experience of the clinician and presence of a spontaneously breathing patient. Cricoid pressure during endotracheal intubation can reduce the risk of aspiration, although it may also reduce the view of the larynx. Laryngeal manipulation by backward, upward, and rightward pressure, known as burp, on the thyroid cartilage can aid in visualizing the vocal cords. When the addition of cricoid pressure compromises the view of the larynx, it should be discontinued or readjusted. This and drug administration require assistance from additional team members. If orotracheal intubation is unsuccessful on the first attempt, or if the cords are difficult to visualize, use a gum elastic bougie and initiate further preparations for difficult airway management. Orotracheal intubation requires several assessments to ensure proper placement. If orotracheal intubation is unsuccessful on the first attempt, or if the cords are difficult to visualize, use a gum elastic bougie and initiate further preparations for difficult airway management. After orotracheal intubation, institute assisted ventilation and secure the tube in place. When the patient is moved, reassess tube placement. The use of anesthetic, sedative, and neuromuscular blocking drugs for endotracheal intubation is potentially dangerous, but sometimes the need for an airway justifies the risk. It's important to understand their pharmacology, be skilled in the techniques of endotracheal intubation, and be able to secure a surgical airway if necessary. The most dangerous complication of using sedation and neuromuscular blocking agents is the inability to establish an airway. If endotracheal intubation is unsuccessful, the patient must be ventilated with a bag mask device until the paralysis resolves.
Looks like you have some swelling here on your neck. Take it nice and easy. Take some slow, big, deep breaths. Travis, can you hold his neck for me? It looks like you got some swelling in your neck, Mike. We're going to have to put a breathing tube in for you, okay? So we're going to give you some medications to relax you, and we can put you to sleep here. Betsy, can you put a little cricoid thyroid pressure on there? All right. Okay, can we get the medications, please? All right, medications going in. Let me bag him. All right, good. All right, we got my suction, my laryngoscope, and tube. Okay. And let's put the tube in. I see the cords nicely. Give me just a little more pressure. Okay, good.